Under the leadership of President and CEO Andrew Dreyfus, Blue Cross Blue Shield of Massachusetts has created groundbreaking programs that expand access to care for people with opioid use disorder and other substance use disorders. And they also have provided education and other resources to reduce stigma. To hear more about their leadership on this issue, we are now joined by Dr. Gregory Harris, Senior Medical Director of Behavioral Health at Blue Cross Blue Shield of Massachusetts. Dr. Harris is a board-certified adult psychiatrist with a master's in public health and over 20 years of practice, and he continues to see patients in a part-time clinical practice. Dr. Harris?
Thank you very much. I'm happy to be here and share some of the approaches we have tried over the last several years. Do we have the next slide? Oh, thank you. So I'm going to highlight a few areas of focus. This is sort of the scope of things for the opioid epidemic as well as for other substance use disorders. And I should say Blue Cross and Blue Shield of Massachusetts is a local, mostly commercial health plan based in Massachusetts. About 2/3 of our members are based in Massachusetts. We've gone all the way to the end of the talk here. So I'm going to take you through some elements related to prevention, intervention, treatment, and recovery, and I'm particularly going to focus on some treatment ideas, but we'll start first with prevention. Next slide, please. So starting in 2012, you've seen the data from the other presenters about the rise in the opioid epidemic related to prescription drugs. And our leadership began when we began to work with state leaders in Massachusetts as well as with the medical society and our local providers to jointly work on a collaboration for prescription drug safety. And this program in 3 years removed 21 million sort of opioid pills from circulation by jointly coming up with criteria for reducing those initial opioid prescriptions for a variety of medical conditions, working at the level of changing physician behavior on the ground. Not as easy a thing to undertake, but in a collaborative manner with our providers, we were able to initiate this program. The program is still, in effect now and reinforced in many other areas with prescription drug monitoring programs and requirements in the state. But as a plan, we were really important to having that go into effect. And we have the second lowest rate of opioids prescribed in the Blues nationally. Another prevention intervention was an investment in something called Drug Story Theater, which is really a primary prevention program aimed at youth. And this was a local development using storytelling to reach out to youth who have had experiences with drugs. And on the recovery side, we were also a founding member of RISE Massachusetts. Next slide, please. On the intervention side, we were first in the nation in health plans to provide an opioid toolkit. So this was with naloxone to reduce overdose, and this was targeted at our employer groups, our accounts, to implement the Narcan toolkits in their employment. These are municipalities, large companies, small companies, The librarians, we're finding many people with overdose in some of our communities, and having these kits available in the workplace was life-saving for many people. And that was something we worked with, creating the kits and then distributing the kits with our employers. We also removed copays and cost sharing for Narcan, and this access has become easier over time, but you could walk into a pharmacy and get a Narcan prescription. Our ID cards have substance use and support services for mental health. Now, we at Blue Cross, we have an integrated medical, surgical, mental health, and substance use program, so that when people are calling in, they're getting us at Blue Cross, and we have a series of professionals behind the scenes that can help our members find treatment. And then we instituted Learn to Live. So next slide, please. I'm going to talk a little bit about our program. So one of the things that we find on the ground is we have a very decentralized healthcare system in the substance use world in particular. We really have three systems of care. There's the medical, surgical system, the mental health system, and the substance use. And so, finding a clinician with the right specialty is non-trivial for a lot of people. And so we have provider directories and all sorts of tools, but on this is sort of a continuum of our electronic tools, Find a Doctor tool, reaching out to member services, and then case management. And our case management team, social workers, nurses, backed up by physicians and psychologists, can help our members try to find the right level of care if they reach out to us. Not everyone thinks to reach out to the insurance company for this type of assistance, but we've really been pushing the notion that we could be the ally of our members trying to find the right care at the right time and helping take off some of the burden. I was involved with a provider search, just today, where a person got, a list of 20-something doctors. We could make those calls, see who had availability, and try to direct our members in real time. So this is, before they really get into treatment and when they're not sure where to go. Next slide. And then another thing that we implemented is Learn to Live. Now, this is a mental health tool. It's cognitive behavioral therapy, sort of a skills-based therapy is some of the foundation of this. This isn't treatment, though. But this tool really aims at 5 main domains: stress and anxiety, depression, social anxiety, substance use, and insomnia. So this is not an opioid addiction tool, but this is aimed at our membership, many who aren't getting treatment at all. So we know that really only 10% of people with substance use disorders and maybe 50% of mental health conditions really even seek treatment. And so you're going to hear more things that we're doing to try to bring our members who are struggling with substances into the healthcare delivery system. Learn to Live is one tool, and we've had 1,000 members a month doing this tool, benefiting from this tool, and learning about all these areas of focus. And it's really a screening, because if they get notification if they should seek further help than this. But we're getting people who have never, 60% of people who are on this tool have sought no mental health care before this tool. Next slide, please. So I'm going to shift a little bit to treatment. So we've done a number of things for medication-assisted treatments in particular, and for admission. So the first on this list is no prior authorizations for detox admissions from emergency departments. We really think of this as urgent, emergent medical care, like if there's a stroke, you get admitted. If you have a suicide attempt, you get admitted. If you need a detox, you get admitted. We have access to medication-assisted treatment. This has been over a period of time to make sure that as many of our members as possible have access to all types of medication-assisted treatment. reducing prior authorizations, reducing the deductible, eliminating the deductible and copay for methadone, which a lot of commercial, is new for commercial plans to do this. Not all of our employers sort of understood this, and it's sort of a work to work with our employers to understand this really does need to be part of a standard medical benefit, medication-assisted treatment. And what we find is our members who are actually engaged have admissions rate and costs really drop. And the more engaged they are with medication-assisted treatment, the better they do. Not surprising to this audience, but that data is very compelling when we speak with our accounts and employers. We've also expanded our network of opioid treatment providers and other substance use providers, eliminated prior authorization for our routine outpatient visits for mental health and substance use disorders. So hassle and payment are what our providers complain about, and we've tried to make it as friction-free as possible for our providers so that our members can get care. And then I'm going to talk about a few of these options listed here that have to do with contracting, collaborative care management, and aware recovery care. And I will end a little bit with talking about telehealth. So next slide, please. We were early, about 10 years ago at Blue Cross, with contracting using value-based contracts, accountable care organizations with most of our medical providers. That occurred about 10 years ago, and it's been well studied, in peer-reviewed journals in the New England Journal of Medicine for a highly effective sort of reorganization of our medical practices. And that's really been an important thing to get our practice thinking about the total care of the patients that they treat, our members, and adding mental health and substance use disorder care as part of the outcome measures that these groups are accountable to. So that's been going on for a while, and that's been an improvement. But what we've also then added in this last year is, if you go to the next slide, an incentive program for psychiatric collaborative care management. This is a model, and I want to take a little bit of time. It's not specific to substance use disorders, but what we see is that our medical providers are still somewhat siloed from mental health and substance use providers. And this is a model of care that's population-based, brings a psychiatric consultant alongside a primary care practice with a behavioral health care manager sort of in the center of the treatment, really the patient's in the center of all of this activity that goes around. It's paying for a population-based model for the primary care's practice. So the behavioral health care manager is screening the population of that primary care and intervening. So common concerns like anxiety, depression, substance use disorders, those are really three of the primary things. It's why we have our Learn to Live program. These things are screened, picked up, and the behavioral health care manager becomes the first point of contact with the member. Can consult to the psychiatrist can consult to the PCP. The team gets the benefit of the psychiatrist being involved and can initiate care without even requiring sort of the traditional care model of seeing an individual patient going to an individual physician or psychotherapist. And then if subspecialty care is needed, the team can then initiate that. What this gets our practices doing is really leaning into mental health and substance use disorders in a way that they hadn't really done before, because it provides an internal resource to the primary care practices. So it's trying to work our medical practices to pay attention to these issues, become accountable for them in their value-based contracts, and be incentivized for really thinking about really integrating mental health and addiction care into the care of all of their practice. Next slide, please. And then what we've also added in this past year is a relationship with a group called Aware Recovery. And Aware Recovery has really a very novel, home-based, comprehensive program that really I've put here in sort of a salmon color where they fit in the continuum from inpatient. So the kind of patients that Aware Recovery sees are people who've tended to be in and out of rehabilitation programs and detoxes. So they have significant substance use disorders, but some of them improve. They have a course of treatment and they recover and they get better. But many people end up in and out of treatment. And the idea with Aware Recovery Care is to meet them more in the home environment and to help them build skills themselves with family members, intervene with the family, the providers, and really wrap around care for our members in their home environment. And the program is built around phases of a few months, and they tend to be in this program for a year. And they have next slide, please. Really excellent success rate in engagement and longer-term recovery, which is a kind of program that we really want to see more of. A program to really stop the cycle for our sickest members. So with Learn to Live being more about screening and collaborative care about integration, this program is really aimed at our members who are well along a journey of substance use, and they're really trying to break a cycle and involve their family, try to preserve their job, and not go further downhill and with more and more serious consequences of their substance use. Next slide. And I just want to end my piece on talking a little bit about telehealth because this is just to show a little bit of data and also to leave us with a question of what comes next with telehealth. We at Blue Cross went from 200 telehealth claims a month to 40,000 in the peak of the pandemic, and 8.8 million telehealth claims. 54% of claims that we receive are for mental health, and within that, mental health and substance use disorders. And we have overall utilization. You go to the next slide. This is just some data that we released about in this 2 months ago. Increase in outpatient mental health services, and we were seeing that year over year before the pandemic, but this is a sharp increase of 20% just over the past year. Increase for substance use spending, or kind of astounding 9,500% increase in telehealth visits. I see patients still, and I went from 0.5% telehealth prior to the pandemic, which was a higher percentage than a lot of my colleagues, to 100%, and have stayed at 100%. And we'll just go to the final slide. So the top graph is telehealth nationally for all specialties. It peaks around 51% and it drops to about 18%. So there was a sharp uptick in telehealth in all medical specialties, and then dropped to 17%. I pull out psychiatry in the lower one, and you can see that it goes up, and it's still up, and it's at 73%. And that's about consistent with what we see at Blue Cross as a company. This is national. This is just data broadly, but it's consistent with our Blue Cross data. So we see our mental health and substance use providers still using telehealth, and it's not decreasing. And as a plan, we are really we're intending to pay at the same rate for telehealth visits versus an in-person visit. And we're thinking really broadly because these numbers, a lot of them are focused on outpatient psychotherapy and some of those services. But what we're also seeing is a huge uptick of telehealth in intensive outpatient and partial hospital programs. It's harder to tease out with those programs what's being done on the claims side of telehealth or not, but we've broadly allowed those. And our teams really hear that our members are attending a lot of programs remotely that wouldn't have kept going if they hadn't had telehealth availability. And in some cases, going on and better, fewer no-shows up from the provider side or more engagement from the member side by having a telehealth option. So while the opioid numbers that my colleagues have showed are really alarming, these numbers have allowed a lot of care to go on that, were it not for telehealth, would not have happened. And I think we would have been in a much worse state. And I think that this is going to be an important story for access to care in all environments. You know, we're in the state of Massachusetts. We have rural and urban. Our urban members get as much benefit from telehealth as our rural, because access is difficult in the city as well as in a more rural area. So this is just food for thought, and I'm going to, next slide, and we'll end it there. And thank you very much.
Thank you, Dr. Harris, for ending us on that bright spot and for your continued leadership working with your members and community partners.